Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes and Lecture. So in the previous video we have discussed till differential diagnosis. Now we will move on forwards. Let's begin with the name of Almighty. So let's discuss from diagnostic approach. The diagnostic workup for hypothyroidism is highly algorithm driven, relying heavily on third generation chemiluminescent immunometric TSH assays, which poses a functional sensitivity of approximately 0.01 milli international units per liter. So what do you do? So a patient comes to you with hypothyroid symptoms. The initial recommended tests are these two, TSH and free T4, not total T4, not total T3, and not FT3 also. So initial recommended tests are TSH and free T4, FT4. Now you will correlate these two and you will have 5 types of picture. Picture number 1, TSH is elevated more than 10 units and FT4 is low. Number 2 is TSH is mildly elevated but it is less than 10 and FT4 is normal here. Okay. Number 3 is TSH is low or normal but FT4 is low. Number 4 is TSH is elevated and FT4 is high or normal. Okay. Number 5 is TSH is normal and FT4 is also normal. So let's go one by one now. So number 1 is TSH is elevated more than 10 units and FT4 is low. That means the most likely interpretation is overt primary hypothyroidism, meaning patient is having symptoms and is having primary hypothyroidism. What is the next steps? Confirm the diagnosis. Check the anti-TPO antibodies to establish Hashimoto's etiology and initiate levothyroxine replacement. So this is the next important step. So TSH elevated more than 10 and FT4 low. So overt primary hypothyroidism is diagnosed. Now if you want to confirm whether it is due to autoimmune, you order anti-TPO antibodies and initiate treatment. Straightforward, that's all. Then second picture is TSH is mildly elevated and FT4 is normal. Okay. Most likely interpretation here is subclinical hypothyroidism. Subclinical, and FT4 normal will be at the lower range. Remember this point. It will be at the lower range. FT4 will be at the lower range, but not low. So this is known as subclinical hypothyroidism. So what is the next steps we should do? Check anti-TPO antibodies. So high titers of anti-TPO antibodies means annual risk of progression to overt disease approximately 4 to 5% per year. So in these patients of subclinical hypothyroidism who don't have symptoms or any risk factors like pregnancy, okay, so in these patients we should monitor or treat based on symptoms and age. Okay, symptoms like if the patient is having clinical symptoms of hypothyroidism, you need to treat even though the TSH is less than 10 and FT4 is normal. And if patient is pregnant, then also you should treat. So that is the second, that is subclinical hypothyroidism. Third one is TSH is also low, FT4 is also low. Most likely the thing is two things you should differentiate. Number 1 is A, central hypothyroidism, B, Sick Euthyroid Syndrome, SES. Next step, do not trust TSH alone. Now because we are suspecting central hypothyroidism, so first what you should do exclude a severe systemic illness. Okay, if there is no severe systemic illness, then evaluate for pituitary function, like you can order MRI, Sella turcica, and you can order serum cortisol, AM, okay, ACTH, FSH and LH, insulin like growth factor for growth hormone. So because when there is central hypothyroidism, maybe some other hormones secretion is also affected. That's why apart from evaluating for central hypothyroidism, pituitary disorder, you are also evaluating for other hormones deficiency like growth hormone deficiency. For that, IGF, insulin growth factor 1, cortisol for cortisol addisonian deficiency. So FSH and LH for reproductive hormones deficiency, like that. So when the TSH is low and FT4 is also low, so either it can be central hypothyroidism and second it can be Sick Euthyroid Syndrome. The fourth one is TSH is elevated and FT4 is high or normal. TSH is elevated and FT4 is high and normal. So in that thing, what you should think is, so remember TSH takes time both to come to normal TSH takes time. When you treat also, it takes time from 4 to 6 weeks. It will take to come to normal range. In that case, if the patient is having FT4 normal or FT4 high, that means the patient has recently taken the thyroxine tablet. So the most likely interpretation is poor adherence. Patient is not taking the tablets properly. Okay, poor compliance, or it can be due to testing defect, or it can be hormone resistance. So next steps, what should you do? You should rule out poor medication compliance. Taking pills just before testing normalizes T4, but TSH remains high because it will take time. Rule out assay artifacts like biotin interference. Remember, biotin is a vitamin which will interfere with this measurement of TSH and means thyroid profile. It will interfere and it will cause defects in the measurement. So that's why when patient if a patient is on biotin, usually for some hair or skin disorder, then he should be informed that he should quit taking the tablets of biotin for 3 days, at least 3 days. Then he should undergo for measurement of this TSH and FT4. Consider thyroid hormone resistance also. Consider thyroid hormone resistance, meaning peripherally maybe selenium deficiency. Okay, when there is selenium deficiency, deiodinosis will not work. Okay, so you can consider that also. But the most common cause is this one. Poor medication compliance is the most common cause. And second one, you can look at SC artifacts. Third one is thyroid hormone resistance. SC artifacts due to mainly biotin. So when TSH is high and FT4 is normal or either high. Now TSH is also normal, FT4 is also normal. That means patient is euthyroid, meaning normal. There is no primary thyroid dysfunction. Symptoms are likely non-thyroidal in origin. Same thing in the form of a box. So TSH is more than 10 and FT4 is low. So it is overt primer hypothyroidism. Confirm the diagnosis. Check anti-TPO antibodies. Monitor or treat. In this case, you need to treat. Okay, you need to treat straightforward. Now, second case is TSH is increased but less than 10. FT4 is normal, so it is subclinical hypothyroidism. In this case, you should check anti-TPO antibodies and monitor or treat based on symptoms or age. TSH is mildly elevated and FT4 is low. TSH is mildly elevated and FT4 is low. Now it is confirmed again. It is subclinical hypothyroidism again. Again, you should check anti-TPO antibodies and monitor or treat based upon the symptoms or age. Now TSH is also low, FT4 is also low. Two things will be there: central hypothyroidism, Sick Euthyroid Syndrome. And if TSH is in the normal range and FT4 is normal, then it is euthyroid state. Okay, that's the thing. So that's how you should interpret these tests. Explaining the clinical logic and decision points. TSH as screening tool. TSH as screening tool. Anterior pituitary thyrotrophs are highly sensitive to small changes in free T4. A 50% drop in FT4 triggers a 10 to 100-fold logarithmic rise in TSH. Therefore, a normal TSH reliably excludes primary hypothyroidism. So that's why we can use TSH as a screening tool to know whether the patient is hypothyroid or not. So you can use TSH as a screening tool in those patients who are not previously known thyroid, don't have previously known thyroid disorder. So for screening, we can use TSH only. Now free T4 versus FT4 versus total T4. Total T4 includes bound and unbound hormone and is affected by thyroid binding globulin variations like pregnancy, oral contraceptives, cirrhosis meaning liver disease, nephrotic syndrome. So FT4 measured via equilibrium dialysis or valid analog assays reflects the true biological active pool. That's why you should use FT4, because total T4 is affected by many factors. Role of anti-TPO antibodies. Once hypothyroidism is confirmed biochemically, anti-TPO antibodies establish Hashimoto's thyroiditis as the cause. In subclinical hypothyroidism, high titers of these antibodies warrant closer monitoring or earlier intervention. Fallacy of FT3, free T3. Free T3 is not reliable for diagnosis. The failing thyroid preferentially secretes T3 and under high TSH stimulation and peripheral D2 deiodinase upregulation maintains normal FT3 despite falling FT4. FT3 only drops in late stage disease, making it insensitive as a marker. So the thing which happens is when there is hypothyroidism, so thyroid gland will secrete more and more of T3, and in the peripheral tissues D2 deiodinase is activated more and more, and that's why initially you will have normal concentration of T3. It will fall in the later stage of this disease. That's why it is not recommended to use to diagnose hypothyroidism. TSH and free T4 are recommended. Okay, that's about the clinical logic behind this test. Common diagnostic pitfalls and artifacts. Biotin interference. High dose biotin interferes with strapadin biotin immunometric assays. Excess biotin prevents capture antibody binding to solid phase. So what will happen? Falsely low TSH and falsely high FT4 or FT3, mimicking biochemical hyperthyroidism. So if patient is on biotin and you are measuring that thyroid tests, then you will get a picture of hyperthyroidism. Because of this biotin, you get a picture of hyperthyroidism. That's why biotin should be discontinued at least 3 days before thyroid function testing. Second is heterophile antibodies. Host antibodies against animal immunoglobulins in assay reagents artificially bridge or block assay complexes. The result is falsely elevated or depressed TSH results. If clinical suspicion is not equal to lab result, request serial dilution, heterophilic blocking tube step, or use an alternative assay platform. So these two things we should remember. Okay, biotin interference and heterophilic antibodies. Now coming to the management strategy. Okay, so management strategy. Okay, the overarching objectives of treatment are to restore physiological thyroid status, reverse biochemical abnormalities, and meticulously prevent iatrogenic hyperthyroidism. So objectives of treatment. What are the objectives of treatment? Now, resolve the clinical symptoms, normalize the serum TSH, restore the physiological status, reverse the biochemical abnormalities, millisodium, prevent iatrogenic hyperthyroidism. These are the objectives. General principles. So T4 LT4 optimization, European Thyroid Association 2025 guidelines. So oral levothyroxine LT4 is recommended as undisputed standard of care. Okay, it is a reservoir prohormone. Okay, it is activated to T3 in the peripheral tissues. It has a long half-life of 7 days. So stable once daily dosing is possible, and it is peripherally converted to T3, whereas T3 has a low half-life. So T3 is actually used in conditions like Myxedema Coma, where there is requirement of T3 also. Okay, if you give T4, it will take time to act. Okay, because the deiodinases are down regulated in that state, in Myxedema Coma state, they are down regulated. That's why we need to give this active form of T3 in those states. But in normal individuals who are not who have not gone to that critical stage, so starting with LT4 is enough. How do you initiate and how do you titrate? Standard adult dosing, young and healthy individuals. Calculate the dose. How much? It is 1.6 to 1.7 microgram per kg per day. So this is the dosage. In older patients or cardiac patients, meaning older meaning more than 65 years of age, or who have a history of coronary artery disease, so the dosage is not 1.6 microgram per kg per day, but you should start at a low dose, 12.5 to 50 microgram per day, and practically it should start at 25 microgram per day, and then you should titrate slowly. Why this matters? LT4 dramatically increases the myocardial oxygen demand. Coronary perfusion is compromised by atherosclerosis, can precipitate unstable angina, arrhythmias, myocardial infarction. That's why in the elderly patients and those patients who are having coronary artery disease, you should start at a low dose. It is 25 microgram per day. How do you titrate? So LT4 has a 7-day half-life. Steady state is reached in approximately 6 weeks, 4 to 6 weeks. TSH should be rechecked not earlier than 4 to 6 weeks after dose adjustment. Titrate the dose. How much you will titrate? Either 12.5 or 25 microgram based on the TSH target. So you not titrate like 50 microgram directly. So slowly you will titrate. So if the patient is young and healthy, you can titrate in 25 microgram like doses, and in older patients you can titrate in 12.5 microgram increments. Okay, That's how you titrate, and you should measure after 6 weeks, okay, starting the therapy. So initial titration. Then next comes administration, optimization, and adherence. How you should give, you should instruct the patients. These things are very important. This optimization of administration. So you should give the information of the patient that the patient should take ideally the tablet empty stomach, ideally at least 1 hour before the breakfast in the morning, or more than 3 to 4 hours at the evening bedtime. So nighttime meal, so 3 to 4 hours after the nighttime meal, or at least 1 hour before the morning breakfast. So that's how you should say the patient, at least 1 hour, not less than that. Okay, why? Because volatile absorption and narrow therapeutic index. Now you should also interrogate the patient about the drug interactions which impair the absorption of this T4. Calcium supplements, iron supplements, proton pump inhibitors, sucralfate used for GRD, okay, or peptic ulcer, aluminum hydroxide, again antacid, cholestyramine used in liver diseases, high fiber soy products. Remember shortly as iron and calcium tablets, number 1. Number 2, stomach tablets, stomach preparations. So these things, no, they bind LT4 in gut, or they alter the gastric pH, so that will decrease the absorption of T4, and more dosage the patient, you will go on increasing the dosage because of this. They will interfere with the absorption of this LT4. So what to do then if the patient requires this also? So you should say the patient minimum 4-hour gap should be there after taking the thyroxine. At least 4-hour gap should be there. So after 4 hours he can take these supplements. Okay, that thing should be informed to the patient. Now that is one thing. So these are, they impair the absorption here. Okay, now some drugs accelerate the clearance of the thyroxine. Which are those drugs? Mainly anticonvulsants and rifampin, an anti-tubercular drug. So these drugs accelerate the metabolism of T4 and it will get excreted. So this will frequently necessitate a higher maintenance dose, because if the patient is epileptic, then you can't drop the patient cannot stop these medications. That's why patient may require higher doses in these cases. Okay, so some drugs decrease the absorption of LT4 and some drugs increase the excretion, increase the metabolism of thyroxine. So that you should inform the patient, and how to take that you should inform the patient. That's about treatment of overt hypothyroidism. Okay, how to start, how to titrate, and what instructions you give to the patient. Now coming to treatment of subclinical hypothyroidism and hypothyroidism and type 2 diabetes relationship. So number 1 is subclinical hypothyroidism treatment. So what you will have, there will be elevated TSH and normal FT4. Now you should see how much the TSH is elevated. Now if the TSH is elevated more than 10, then straightforward you start the levothyroxine therapy. If the TSH is elevated more than 10 units, then you straightforward start the levothyroxine across almost all age groups. Why? Because high rate overt conversion and adverse CV outcomes are there if you delay the therapy. That means the patient will definitely develop hypothyroidism in the coming days, and the patient will have adverse CV outcomes if he has this kind of hypothyroidism, meaning subclinical hypothyroidism, where the TSH level is more than 10. So what are the adverse CV outcomes? Patient will have progressive atherosclerosis or heart failure or hypercholesterolemia. So these are all bad things which are going to happen to the heart. No, that's why in more than 10 minutes you should start. Now one thing, if the TSH is elevated but it is not more than 10, it is less than 10, then you should check the age of the patient. If the age is less than 65 years and the patient is not having any symptoms or any high risk, first okay, we'll go step by step. If the patient is less than 65 years, then treatment is required. A trial is recommended if at least one condition should be present in these 3 conditions. What is one condition? Patient should have highly specific symptoms for thyroid, or patient may be pregnant or she may be planning to become pregnant. Or third one is coexistent conditions like atherosclerotic cardiovascular disease or heart failure, severe dyslipidemia, metabolic syndrome, especially when the TSH is more than 7 units per liter. Metabolic syndrome, so lipid profiles, if you order, that will be bad, and the patient will be fatty, patient will be obese, patient may be having diabetes, patient may be having hypertension. So in these patients, especially if the TSH is between 7 to 10, then you should start therapy in these patients also. So these are the three kinds of things. If these three things, number 1 symptoms, number 2 pregnancy, number 3 any heart related factor like coronary artery disease, heart failure, and hypercholesterol, metabolic syndrome, and severe dyslipidemia. So these are all the things which are concerning to the heart. So in these patients you should start therapy even though the TSH is less than 10. Okay, if the patient is less than 65 years. Now if the patient is elderly, say more than 70 years or say more than 65 years, okay, and the patient is having TSH less than 10, then what is favored is wait and watch strategy is favored. Mild TSH elevation is normal with aging. Mild TSH elevation is normal with aging. And the next concept behind wait and watch policy is avoid profound risk of iatrogenic hyperthyroidism. What is that? There is a high risk of atrial fibrillation and osteoporotic fractures in these patients. So there is a risk of cardiovascular events and fracture risk in these patients who are aged more than 70 years or say 65 years. Okay, so this is how you proceed in patients subclinical. If the TSH is more than 10, straightforward start the levothyroxine therapy, otherwise the patient will have bad cardiovascular outcomes. If the patient is having less than 10 TSH but more than 5.5, then you should see the age of the patient. If it is less than 65 and any of the three conditions is met, meaning first, number 1 condition is no specific symptoms or signs, number 2 is patient is pregnant or planning to become pregnant, number 3 is patient is having cardiovascular risk factors like coronary artery disease, heart failure, dyslipidemia, and metabolic syndrome, especially if TSH is more than 7, then you should start the therapy. Now if the patient is elderly, more than 65, more than 70, then you should have a wait and watch policy, because with normal aging TSH is usually elevated more than 65, more than 70. Okay, if you give in this case, if you start the therapy in this case when the TSH is less than 10 in elderly patients, then they have a high risk of atrial fibrillation and osteoporotic fractures. That's all about the subclinical hypothyroidism management. Now the section 2 is hypothyroidism in type 2 diabetes mellitus. Important thing. So there is more than 20% prevalence of hypothyroidism in type 2 diabetes mellitus and hypertensive patients. So those patients who are having diabetes mellitus along with hypertension, 20 in 100 patients will have hypothyroidism also. That's how you should screen these patients routinely. Okay, so routine screening is recommended for early diagnosis. How do you screen? So TSH is a very good tool for screening, and you can screen by anti-TPO antibodies also. So TSH is a very good thing to screen. So patients who are having diabetes mellitus along with hypertension, they more than 20% of those patients will have hypothyroidism. You should screen routinely in these patients. Okay, every 3 months you should monitor these patients with diabetes mellitus and you should screen them, preferably with TSH. What is the physiological impact and mechanisms? Unchecked hypothyroidism will exacerbate dyslipidemia, that will increase the cardiovascular risk and promote weight gain. So one thing is that will cause dyslipidemia, and dyslipidemia further increases the cardiovascular risk. Second thing is it promotes the weight gain, and weight gain will increase the insulin resistance. So the medications which are given for diabetes mellitus, they will go on increasing. Okay, now this is one thing. So there will be dyslipidemia and there will be weight gain. There will be dyslipidemia, there will be weight gain, and then there will be altered glycemic control kinetics. How? They'll be by reducing the clearance of exogenous insulin, so predisposing patients to unpredictable hypoglycemic episodes. Okay, unchecked hypothyroidism, that means very important. Oh, this is very important thing. Okay, so patients who are having hypothyroidism which is not controlled, meaning the patient is having hypothyroidism but he is not treated with LT4, so he can have 3 things. To conclude, he can have 3 things. So he will have an increased cardiovascular risk, number 1, because of dyslipidemia. Number 2, he will have increased insulin resistance. Number 3, he will have unpredictable hypoglycemic episodes. Why? Because this unchecked hypothyroidism will decrease the clearance of insulin. Okay, so this is a very important relationship between diabetes mellitus and hypothyroidism. Okay, this should be known to us. So this according to this ITS consensus 2024 and RSSDI guidelines 2021-2024. Okay, so that means every DM plus hypertension patient should be routinely screened for hypothyroidism because of these reasons only. Okay, now coming to the treatment table, drug names and dosages. Okay, so LT4 synthetic thyroxine stand monotherapy converted peripherally to T3, full replacement dose 1.6 micro mcg per kg per day. Elderly or coronary artery disease 12.5 to 50 mcg per day. Contraindicated in untreated adrenal insufficiency because there is a risk of Addisonian crisis. Half-life is approximately 7 days. Take on empty stomach. Target, this is important. So what should be our target when you are giving LT4? Target is in the lower half of the reference range of TSH. So normally it is 5.5 up to 5.5, 0.3 to 5.5. Lower half means less than 2.5. Okay. So our target should be, TSH should be less than 2.5, more than 0.3. That should be our target. Okay. Then levothyroxine, LT3. So synthetic triiodothyronine, highly active, rapid onset. If you are treating with this, but it is not treated with this, but if you are treating, initially it is given 25 mcg per day, titrated slowly. Replacement dose 25 to 37.5 mcg twice daily, rarely used alone. Okay. So this is contraindicated. LT3 is contraindicated in cardiac disease, pregnancy, contraindicated in cardiac disease and pregnancy. Short half-life causes supraphysiological T3 peaks and it is arrhythmogenic, not recommended for long-term monotherapy. Okay, so it is contraindicated in cardiac disease and pregnancy. Okay. Desiccated thyroid extract from pork, biological extract containing T4 plus T3 in variable non-physiological ratios. Okay, so routine replacement is not indicated by these. Contraindicated for routine use, that's all. Just remember that thing. This is important. Intravenous levothyroxine, parenteral formulation bypassing the GI tract. Loading dose is 200 to 400 mcg and maintenance dose is divided by 4. 1/4 dose is the maintenance dose. It is 50 to 100 mcg IV daily. Indicated for Myxedema Coma or severe paralytic ileus due to ileus. Okay. So IV dose is approximately 75% of the oral equivalent. That means if the patient was taking indicated for Myxedema Coma or severe paralytic ileus, IV dose approximately 75% of oral equivalent. Okay. Or if you don't know the dose, just give 200 to 400 mcg as bolus dose, then 1/4 of dose as the maintaining dose till the patient is able to take orally. That's how you treat. Glucocorticoids like hydrocortisone. This will prevent acute adrenal crisis in severe hypothyroid states. 50 to 100 mg IV every 6 to 8 hours should be given. Okay, hydrocortisone. Must be given before IV thyroid hormone in Myxedema Coma or severe central hypothyroidism. Two things. In Myxedema Coma or severe central hypothyroidism until adrenal insufficiency is excluded. In severe central hypothyroidism, you should give this until adrenal insufficiency is included. Okay, in Myxedema Coma and in severe central hypothyroidism. Okay, that's about the dosages. Okay, now we'll move on to forwards. Special situations or pitfall in detail. Okay, number one special situation. Okay, so that is Myxedema Coma. So it is an endocrine emergency. How do you define? It is catastrophic end stage decompensation of long-standing untreated hypothyroidism. It is a rare event but devastating. Mortality exceeds 20 to 50% despite aggressive intensive care. What is the pathophysiology? So there will be intracellular T3 depletion, generalized loss of metabolic thermogenesis, central respiratory drive, depression, cardiovascular collapse. That's pathology. What's the presentation? I said initially, one is temperature and second is CNS manifestation. This will be the presentation. So coma is a dangerous red flag. Coma is a dangerous misnomer actually. Initial presentation involves altered sensorium, extreme lethargy or psychosis. So mainly psychiatric manifestations. Okay, myxedema madness, psychosis, or altered sensorium, delirium. So this is a red flag. Okay, because why? Because these patients will eventually go into coma. So I said the classical hallmarks are severe hypothermia, often less than 30 degrees Celsius. Okay, easily missed unless a low reading rectal thermometer is utilized. Second one is hypoventilation that leads to carbon dioxide narcosis and respiratory acidosis. This is important. And related to heart, bradycardia and hypotension. Related to kidneys, severe hyponatremia. Why? Due to decreased renal free water clearance. Okay, so you should remember like this: in the brain, then lungs, then heart, then kidneys. Okay, that's about the clinical presentation of myxedema coma. It is a misnomer actually. First patient will present with psychiatric or manifestation of altered sensation, then he will progress to coma. Now, how do you manage myxedema coma? Critical ICU protocols and management pitfalls. Number one is rule out adrenal crisis. Must administer hydrocortisone prior to thyroid replacement. Dosage is 50 to 100 mg IV every 6 to 8 hours. Prevents fatal adrenal crisis. Never administer thyroid hormone alone. The second thing is hormone replacement and adjunctive IV levothyroxine. So you should give, as we have discussed, what is the dosage? 200 to 400 microgram IV push. And adjunctively you should give levothyroxine 5 to 20 microgram IV initial push. Okay. One note here, T4 to T3 conversion is impaired in myxedema coma in these states. That's why you need to give T3 also in these states. Okay. So there will be hypoxia and hypothermia. So this hypoxia and hypothermia will impair the D1 and D2. So D1 and D2 are required for conversion from T4 to T3. So they are impaired because of hypoxemia and hypothermia. Because enzymes require a specific temperature to act. So there is hypothermia and hypoxia, D1 D2 deactivated. That's why you should give T3 also. So levothyroxine rapidly restores the intracellular active hormone levels. Okay, but caution, you should use it cautiously in patient with coronary heart disease. Okay, because there is a risk of fatal fibrillation in these patients. So that's the main and the root treatment. What is the supportive care? So you should support the ventilation of the patient. Most of the patients require mechanical ventilation. Treat the neuropsychiatric manifestation. If the patient has seizures due to sodium deficiency, then you can use cautiously 3% or hypotonic saline, 3% NS you can give if the patient has seizures. Okay, that's one thing. So mechanical ventilation and treat severe hyponatremia. Okay. Fourth one, the rewarming pitfall, meaning do not give active rewarming to the patient. Why it is discouraged to give active rewarming? Like forced hot air or heated blankets. Why? Because the cardiac function is already compromised in these patients. If you give active rewarming by forced hot air or heated blankets, there will be sudden peripheral vasodilation, and that will lead to irreversible shock and cardiovascular collapse. So in severe volume contracted patient, active rewarming leads to peripheral vasodilation, dropping blood pressure. Okay. Passive rewarming is encouraged in these patients. What is passive rewarming? Use standard space blankets. Just use standard space blankets to prevent further heat loss. That's all. That is passive rewarming. Don't give heated blankets or forced hot air to the patients. Otherwise, the patient will end up with cardiovascular compromise. So that's about the management of myxedema coma. 4 steps. Step number 1, administer the hydrocortisone. Step number 2, administer LT4 and LT3. Step number 3, give supportive care. Step number 4, passive rewarming. These are the 4 steps. Now coming to the second special context, that is hypothyroidism in pregnancy. Okay. Critical physiology management monitoring. Okay. Key concept, early fetal dependence. So up to 3 months, up to 12 weeks or up to 3 months, fetus is dependent upon the patient upon the maternal thyroid hormones for its development. So why? Because fetus does not have himself the thyroid hormones. That's why he is dependent upon the maternal hormones. So the first 3 months are very important. Fetus entirely relies on maternal T4 transplant and transfer. Maternal T4 is essential for fetal neurodevelopment. Fetal thyroid does not function until the end of the first trimester, up to 12 weeks. Okay. Second thing, maternal physiological shifts and impact. So what happens in pregnancy is, so there is rising estrogen levels, high HCG levels, and high D3 placental activity. So rising estrogen, what it will do, it will increase the thyroid binding globulin, binds more T4, and that's how it reduces the free T4 fraction. High HCG levels, they will cross stimulate the TSH receptor, and thyroid will think that by cross stimulating the TSH receptor, the thyroid a type of negative feedback is given to the thyroid gland, and more thyroid hormones are not secreted. So this is how there is a physiological TSH drop in the first trimester of pregnancy. So the HCG, human chorionic gonadotropin, it will cross stimulate the TSH receptor. So there is a physiological TSH drop, okay, because of this negative feedback, cross negative feedback given by the HCG hormone. And D3, placenta has D3. So D3 will convert T4 to reverse T3, and reverse T3 is an inactive form. So that's why, because of these three reasons, okay, because of reduced free T4 fraction, and physiological TSH drop, and inactive reverse T3, overall there will be maternal T4 needs will increase in the pregnancy. Very important thing, okay. Now, what are the management pitfalls? Risk of untreated hypothyroidism. What are the risk? Maternal risk, you can divide into maternal or offspring risks. There is a risk of spontaneous abortion. There is a risk of high chance of preeclampsia. Abortion, preeclampsia, high chance of abruptio placentae, high chance of preterm delivery. Four things. Okay, four things. Abortion, spontaneous abortion, repeated abortion if the patient is going on, check thyroid levels. Okay, spontaneous abortion, abruptio placentae, preterm birth, and preeclampsia. These are the four important maternal risks. Offspring risks. So there will be irreversible, remember, irreversible intellectual disability, that is known as endemic cretinism. So once the pregnancy is confirmed, immediate dose escalation is required in those female patients who are already taking medications. How much dose escalation? 20 to 30% dosage escalation is required immediately upon confirmation. Up to 45% is possible. So a simple thing is, you can increase 25 microgram mcg. If the patient has 50, for suppose, then any patient you can give 25 mcg in excess during pregnancy. Or what you can do is, the other method is, and practical method, add 2 extra daily doses per week. To the standard regimen as soon as pregnancy is suspected. Okay, add 2 extra daily doses per week. That's all. 2 tablets extra in 1 week. That's the second method. Okay. Now, key actions and monitoring. Dosing adjustment for pre-existing LT4 patients, meaning patients who are already taking T4. Confirmed pregnancy, immediate dose escalation, 20 to 30% immediately upon confirmation. Monitoring the targets and schedule. Monitoring targets, utilize trimester specific population based TSH ranges. If unavailable, target TSH normalize securely within the lower half of non-pregnant range, less than 2.5 units per liter. Okay, strict control is required. If the patient, and one thing, how do you diagnose pregnancy induced hypothyroidism? If TSH is more than 4 milli international units per liter, then you should treat the lady. That's all. TSH should not cross 4. It is an arbitrary range, is given in McMaster textbook of medicine. Okay, that's the thing. It should not cross 4, and the target should be less than 2.5. Now, reschedule. How you should monitor the patient? Recheck TSH every 4 weeks. First 4 week, first month, second month, third month, 4th month, 5th month. That means up to 5 months, every month you should check the patient. Every month you should check the patient up to 5 months, up to 20 weeks. Okay, up to 20 weeks during the first half of the pregnancy. Every month you should monitor these patients, pregnant ladies. Okay. So what is the concept and what is the mechanism? Why increased thyroid requirement is there in pregnancy? I have explained. And how do you treat these patients? How much dose increment is required? What are the maternal risks and what are the offspring risks if TSH is if thyroid is not treated properly in these patients? And how do you monitor? All things we have discussed. and the most required stage during pregnancy are the first 3 months of the pregnancy. These 4 things we have learned in hypothyroidism during pregnancy. Okay. Now, there is one thing called as amiodarone-induced thyroid dysfunction. Okay, let us see that. Amiodarone is a potent class 3 antiarrhythmic. So it has, as we have learned, 40% of its mass is iodine actually. So it is a kind of iodine load. So features massive systemic iodine load, intrinsic anti-thyroid cellular toxicity. So first we will see mechanism of amiodarone-induced hypothyroidism. So there is massive iodine load from amiodarone. So prolonged Wolff-Chaikoff effect. This will lead to huge iodine influx will lead to prolonged Wolff-Chaikoff effect that will effectively paralyze the hormone organification stage, and TPO will be inhibited. Okay, that will lead to reduced T3 and T4 synthesis. Elevated TSH is the outcome. So that will cause amiodarone-induced hypothyroidism. So this occurs in 10 to 13% of patients who are taking amiodarone. High risk category include high iodine replete regions and patients who are having pre-existing Hashimoto's thyroiditis. Okay. Clinical management, pitfall and strategy. Clinical scenario: patient on amiodarone with life-threatening ventricular arrhythmia and diagnosed amiodarone-induced hypothyroidism. So wrong thing is, do not discontinue amiodarone if it is successfully controlling a life-threatening ventricular arrhythmia. Correct management strategy is treat amiodarone-induced hypothyroidism with levothyroxine. What that means? You should increase the dose of LT4 instead. Okay, levothyroxine should be given and titrated to normalize the TSH. That's the thing. Key insight is higher than average dose is often required in these individuals. So peripheral tissue T4 molecule, T4 is converted to T3. Okay, T4 is converted to T3 by this D1 and D2. This is also inhibited by amiodarone. So amiodarone actively blocks the 5-deiodinase which converts T4 to T3. That will create a state of cellular hormone resistance. So by 2 mechanisms, this amiodarone causes hypothyroidism. One mechanism is prolonged Wolff-Chaikoff effect. Prolonged Wolff-Chaikoff effect that will reduce the production, and peripherally it will inhibit the deiodinase enzyme that will create a state of hormone resistance. That's why these patients require increased dosage of thyroxine. Okay. Now, so last special context, that is the Euthyroid Syndrome, non-thyroidal illness, NTI. The Euthyroid Syndrome or non-thyroid illness, pathophysiology and management. So coming first to the pathophysiology. So in critical systemic stress like sepsis or massive trauma, D1, D2 activity is blocked. So T4 conversion to T3 is blocked. So there is a state of peripheral resistance. Upregulated pathways, so D3 is activated. So D3 will convert T4 to reverse T3, which is an inactive thing. So because of these things, what will happen? TSH will decrease and FT4 will also decrease. Both these things will decrease. But this is to decrease the basal metabolic rate. So this is the adjustment made by the body. Okay, this is the adjustment made by the body. Hormone level alterations in blood. FT3 plummets, meaning it will drop very much. FT3 will drop very much. Sudden concentrations of FT3 will drop in the blood. FT4 can be normal or it can be decreased, and reverse T3 is increased, remember. And TSH will be erratic. TSH profile will be erratic. Initially, because you give glucocorticoids and dopamine, initially TSH will be depressed because of glucocorticoids. Okay. Steroids, remember what they will do? Steroids will increase the binding globulins. So they will, that's why peripheral T4 will be less. Okay. So that will decrease the TSH. And during the recovery phase, TSH will increase slightly. So this type of parabolic, this type of a biphasic wave like thing you will see during the during your initial in the illness stage. TSH will decrease, and recovery phase it will increase, and there is so much drop in concentration of FT3. FT4 can be normal or it can be decreased. So what to do then? Clinical scenario: ICU patient with severe NTI and altered thyroid test. Management pitfall: do not administer exogenous LT4 or LT3. Strictly contraindicated unless there is a history of overt primary hypothyroidism exists. Okay, unless there is history of overt primary hypothyroidism exist. So it is an adaptive metabolic downregulation intended to conserve energy and limit metabolism. So no survival benefit, may exacerbate underlying condition. Correct management strategy, post discharge follow-up should be done. So you should measure the thyroid profile after 6 weeks of his illness and re-evaluate the thyroid function test, and then depending upon the thyroid profile you treat the patient. That's the thing. Okay, so don't treat the patient during the illness stage. If you have what do you call altered function, meaning abnormal thyroid function test, what do you do after discharge? Follow up the patient after 1.5 weeks, and then you again you perform those thyroid function tests, and according to them then you treat the patient. But don't give thyroid hormones in the acute stage. Now this is a visual summary, rapid revision master sheet. Okay, key definitions. Hypothyroidism, deficiency of thyroid hormone leading to generalized hypomedorism plus myxedema, mucopolysaccharides accumulation. Primary hypothyroidism, intrinsic gland failure leading to high TSH, low FT4 in more than 90% of the cases. This is the cause. Central hypothyroidism, pituitary or hypothalamic failure, low or normal TSH, low FT4. Subclinical hypothyroidism, high TSH, normal FT4, early or mild thyroid failure. So treatment depends upon the levels of TSH as well as age and risk factors of the patient in subclinical hypothyroidism. Okay, core mechanisms. Hashimoto's thyroid is the most common cause. Immune tolerance breakdown, CD8 plus T cell cytotoxicity plus fast mediated apoptosis leading to follicular destruction and fibrosis. Presence of anti-TP1 disease movement. Okay. Second, iodine deficiency. Third, cellular action. Clinical pearls. Remember, there is a delayed reflex relaxation because of deposition of mucopolysaccharide in the axons. Okay. Carpal tunnel syndrome, again because of deposition. Okay. Diastolic hypertension. This is because of vasoconstriction because of absence of thyroid hormone. There will be microcytic anemia. If there is microcytic anemia plus Hashimoto's thyroid disease, this will suggest pernicious anemia. Okay, I evaluate for pernicious anemia. If there is macrocytic anemia, and remember, patient of hypothyroidism, they have microcytic anemia because of that cellular rearrangement. Cellular wall gets rearranged in the RBCs. So hypothyroidism patient may have microcytic anemia. But one point to remember is, patient who have Hashimoto's thyroid disease along with microcytic anemia, always evaluate pernicious anemia in those patients by seeing the intrinsic factor. Red flags include central hypothyroidism treatment. Never start levothyroxine before checking AM cortisol. Risk of Addisonian crisis in central hypothyroidism. In central hypothyroidism, never start levothyroxine before you rule out AM cortisol levels. Okay. Myxedema coma, rewarming. Avoid active rewarming, that will lead to irreversible shock. Biotin interference, yes. Patients should stop taking biotin for 3 days before TSH-FT4 testing. If you test with while taking biotin, it will create a false hyperthyroid pattern of thyroid function tests. Pregnancy dosing. Fetal brain depends on maternal T4. Increase the LT4 dose by 20 to 30% immediately after positive test. So this is a rapid revision master sheet. Okay, biotin will create a hyperthyroid state. Okay, this is our last slide, management algorithm. So this is screening. Okay, for screening just use TSH, and for confirming use TSH and FT4. TSH is more than 4.5 and free T4 result. If it is low, then overt primary hypothyroidism. If it is normal, then it is subclinical hypothyroidism. Here, initiate levothyroxine. Dosage in young and healthy patients, it is 1.6 microgram per kg per day. More than 65 years or coronary disease, it is 25 microgram per day. Next step, recheck after 6 weeks. Now TSH is elevated but FT4 is normal. Clinical action is, if the TSH is more than 10, then treat. If it is less than 10, treat if the patient is symptomatic, highly specific symptoms, if the patient is pregnant, or high cardiovascular risk factor like patient has heart failure, coronary artery disease, or dyslipidemia or metabolic syndrome. And in patients who are aged more than 70, just monitor, have a wait and watch policy, because with age the levels of TSH also increase. Okay, now other thing is TSH is low or normal and FT4 is low. So it is either central hypothyroidism or non-thyroidal illness or sick euthyroid syndrome. Clinical action is check pituitary axis, MRI sella turcica, AM cortisol, ACTH. Exclude severe acute systemic illness. And one thing to remember is never ever give in these patients with central hypothyroidism LT4 directly before checking AM cortisol. Always confirm adrenal insufficiency, then you can treat along with treat with levothyroxine in these patients. That's all about hypothyroidism. We have completed the topic of hypothyroidism in detail and each and every point. Hope you have enjoyed. Thank you.